So greetings everyone. Welcome to the 219th session of the online Optom learning series OOLS. And for today's session, we have with us Dr. Deepa Chandrasekaran. Dr. Deepa started her optometry journey in India from the elite school of optometry in Chennai. And currently she is an assistant professor of clinical ophthalmology and visual sciences at the Wedderburn Eye Institute in Nashville, Tennessee, USA. She is a contact lens specialist, and she has a couple of fellowships to her credit. She is a fellow of the American Academy of Optometry. She is a fellow of the International Association of Contact Lens Educators. She is also a diplomate of the American Board of Optometry. She's completed fellowships from the Scleral Lens Education Society as well as from the British Contact Lens Association. She has a vast experience in terms of the optometric, I would say, learning process, where she has done her OD as well as completed her residency in cornea and contact lenses at the UAB School of Optometry. And with that vast experience, she's joined us today on a festive day. I would say it's Diwali all over the globe. So thank you so much for agreeing to do this session on a festival day and early Sunday morning. So that's the dedication what she has in terms of educating people around, and she's going to share with us her interesting cases about contact lenses and how she went ahead and helped. So hopefully we can learn something from what she has taken about. So welcome, ma'am, onto our platform. Thank you so much, for taking time today. And let me just, leave the screen time to you, please.
Thank you so much, Fakhruddin. Thank you for the opportunity. I'm happy to be talking on Diwali Day. So for those who are celebrating, happy Diwali. I was actually born around this time, and that's why I was named Deepa. So, it is special to my heart too. So I changed my title a little bit just because I wanted it to mean something. We do a lot of specialty contact lenses in our clinic. And so I wanted the title to say, My Interesting Specialty Contact Lenses. So what's so special about them? So we will see in each and every case, at the end of each case, why was it special, or what made it special, or what lesson I have learned from these specialty contact lens patients. So what are specialty contact lenses? So Dr. David Kading, he was a year senior to me at Pacific University when I was doing my OD, and he has a specialty contact lens practice in the Northwest. So he wrote an article in Optometry Times are actually designed for patient, treatment outcomes, and they are all catered or tailored to those patients who have either regular or irregular corneas. So we are not going to talk about the run-in-the-mill soft contact lenses that we use on patients who have just farsightedness or nearsightedness or astigmatism, or even soft bifocals. So I have a patient who has a gas-permeable multifocal or bifocal contact lens, as a specialty contact lens. So we're not going to talk about those simple cases, but then we're just going to talk about some of the cases that I have learned a lesson from and how I went about doing the fitting. So as he has also already mentioned, specialty contact lenses can be soft because they can be prosthetic lenses. And then even when you're fitting contact lenses for aphakia, it is considered a specialty contact lens. Or they can be gas permeable lenses, so including orthokeratology. I don't do any orthokeratology in the practice I'm in because we have LASIK surgeons. I work with ophthalmologists in the Department of Ophthalmology. So that is something that I did during my residency and soon after, but then during my private practice and my work here at Vanderbilt, I have not been able to do orthokeratology. So that is something that I miss. But we have enough patients that need specialty contact lenses per se that I am so occupied or I'm so busy with them that in a way I don't miss doing orthokeratology. And then there's piggyback when you have the soft lens first on the cornea and then you insert a gas permeable lens on top. That is a piggyback, and that formed the foundation for the synergized hybrid lenses, which have a hard center and then a soft skirt around them. And then you have the scleral lenses, which can be corneoscleral or semi-scleral or mini-scleral or full scleral lenses. And then I said about the hybrid, which is the hard center, and then a soft skirt. And then we have the prosthetic lenses that are mainly given for patients either as therapeutic, to be able to help with the glare, light sensitivity, and then sometimes even color vision, like the X-Chrome or the Chromogen lenses. And then you have the prosthetic tinted lenses that are to be able to cover a corneal scarring or an opacity that can be made with a black pupil or a clear pupil. So basically, these are some of my contact lens patients whom I have seen over a period of years, and these are the cases that we're going to talk about. Let's see, there you go. Okay, so I'm going to start off with a gas permeable lens in a patient who was fit in a bitoric lens and then a multifocal contact lens. And then we'll jump into hybrid and then scleral and then the prosthetic. So this is my first case. So I'll talk about case, I'll talk about fitting process, and then, a little discount Caucasian male who was referred to our contact lens clinic by the low vision specialist. So he had bilateral degenerative progressive high myopia with astigmatism, and he was actually a current custom toric contact lens wearer. So there are many companies in the US that actually make custom soft toric clinic is Art Optical, because they make the Art IntelliWave silicone hydrogel, either spherical lenses or toric lenses or multifocal lenses as well. Because the range that is available, is much higher, we are able to fit these patients in these lenses. So when I have a patient who is really high myope or a high hyperope, I always reassure them that I can find them a lens that they can wear. Just because we have the advantage of making custom lenses based on their topography and based on their prescription. So the CView Advanced is one of the lenses. As you can see, the prescription is negative 1950, negative 150, axis 160. And then here's the material of the lens, and then the water content, and then the DK over T. So this lens is manufactured by Unilens, and it was supposed to be a monthly lens, or it is supposed to be a monthly lens, but some of the practitioners also use this lens as a quarterly replacement lens. So when I give custom lenses to patients just to help them with the cost, because these lenses are expensive to make, I usually dispense them as a quarterly lens. So that is every 3 months that they have to replace the lenses. So that works out better for the patient. And I usually give Clear Care Solution, which is a 3% hydrogen peroxide system to be used with the lenses, so they also don't accumulate as many deposits. So it is also a group 2, which is the hydration of the lens. So this patient was referred to try gas permeable contact lens to see if it can improve his vision enough to be able to drive. So that was the main motivation for the visit. So the low vision specialist said, why don't you see if this patient can actually improve with hard lenses or gas permeable lenses to be able to drive. So to drive in Tennessee, best corrected vision in one eye has to be 20/40 or better. So the vision with his current soft toric lenses when he came to us, to the contact lens clinic, was 20/100 on the right and 20/70 on the left. Manifest refraction, when we did it, was negative 32 plus 6. So my subjective and objective refraction is in a plus phoropter. So you will see that our refractions are always in plus because I work with ophthalmologists. So one of the things that we ask our ophthalmology residents to learn also is to convert from plus cylinder to negative cylinder and then vertexing. So that is one of the lessons in optics that they have to learn when they work with optometrists, because all the contact lenses that are manufactured are a negative cylinder form. So they work with a plus phoropter. So they need to learn to do this. And we learned that in optometry school, so very early on. So that the prescription in the right eye was negative 32 plus 6, axis 105 with a vision of 2150. So I have converted it into negative cell, and I have also vertexed it just so you can remember this number. So negative 20, negative 3, axis 15 is after vertexing, and this is a soft toric contact lens RX we need to pull or we need to order if we are going the soft toric contact lens route. The left eye is a negative 29 plus 250, axis 70. So again, converting that to negative cell, and then after vertexing, what is a soft toric contact lens prescription that we need to order? That's negative 20, 50, negative 150, axis 160. So it is very possible that when he had seen the previous doctor who fit him in the C-view advanced myopic, and so he was wearing a negative 1950. So as you can see, the astigmatism has not changed much, neither has his axis of the astigmatism. So what did we do? The most common thing that we do in our clinic, if it is a specialized contact lens fit, is we order the lenses based on empirical fitting, meaning we actually do a topography on the patient, and then we do subjective refraction. We call the consultant, and then we give all the measurements, and then sometimes we will have to even email the topography. If I feel like the topography is not so regular, but then the patient does not have any weird corneal conditions going on, then I make it a point to actually send the topography and then do the subjective refraction, and so give those numbers as well for them to be able to design the contact lens. So based on empirical fitting, after talking to the consultant, the right eye lens is optimum comfort, and then these are the base curves, 4225 over 4425, 9.3 diameter, and then the powers were -20, -2575, green with dot. So that is the practice that I've been doing since I was trained in India. All the right lenses will be green tinted, and then all the left lenses will be blue tinted. Green because there is R in green, and then right lens. So it is easy for the patient to remember. So they will know that, if they're not able to see very well, at least they can remember based on the tint of the lens. So left lens or left eye will have a blue tinted lens. So because there is L in blue. So if they swap the lenses, so they come in. So sometimes I have had patients, early on in my career, where they would say they're not seeing very well and they would want to see me. I would always ask them, have you swapped the lenses? They would say no, but then when they come into clinic, I always also tell my residents that there's a reason for this madness. A green always goes in the mouth. Who will also say, I do not want two different tinted lenses. I just want blue or green, and we can make that happen too. So that is the parameter of the contact lens that we ordered. So left eye is 4287 over 4437, 9.3 diameter, -2025 over 2275, and the vision with that was actually 2040. But both lenses were not as comfortable per patient. And then he said that the VA comes and goes, like the vision is not stable. As I blink, it is coming and going. The most important thing here also is, he has never worn hard lenses or gas permeable. Who is, starting to wear a hard lens. The most important thing that you need to also let them know is wearing hard lenses is like wearing a new pair of shoes or high heels, to ladies is what I say. Your feet need to get used to wearing the lens. So the more you walk with the shoes, the better you get, or the more comfortable you get. So same way with the hard lens. If you've never worn them before, this is something that you put in your eye, and then adaptation is very, very important. So I always start off with, say, 4 hours the first day, 6, then 8, then 10, and then 12. So by the time they're able to wear the lenses for 12 hours in a day, they know how the lens fits and how they're able to see with them. So since he was not very thrilled about the lenses, and the goal was for him to be able to comfortably wear the lenses and give the best vision possible, I steepened the base curve of both the lenses by about only a quarter diopter. Didn't change it much because the fit didn't look that bad to me. And, I also increased the diameter of the lens. So from a 9.3, we went to a 9.5, so the lens could sit a little tighter. So it doesn't feel that it is coming and going a lot. So that also improved the centration. So I'm going to show you the picture of the, the new lens that I ordered for the patient. But then before that, I also wanted to go over the topography that that was done in his eye when he came to see us. So as you can see, the right eye had a mean K of 4369, and then there's a vertical bow tie. Okay, so that is with the rule astigmatism of about 2 diopters. And the left eye is on the right side. So that is, again, showing incomplete or central about 3 diopters of ethereal astigmatism with a mean K of 4385. So we have the Oculus Penacam topographer. So that's what we use on all our patients who come for contact lens fitting, especially specialty contact lenses. So I wanted to take this time to actually go over, what we actually look for when we do topography. So The first map is the axial or the sagittal map, and that is the map that you see here. So that is if you can see my mouse, this is the map that I'm talking about. So the axial or the sagittal map, that is one. And then we have the tangential map, which is number two. And then I'm going to talk about relative pachymetry and corneal thickness, and then the elevation map, which is the front, surface of the cornea, and then elevation back, or the posterior surface of the cornea. So the axial or the sagittal map is a 2D image showing the dioptric power of the cornea, centrally, paracentrally, and peripherally, and only up to 9 millimeters though. So warmer colors means that the curvature is steeper, and then cooler colors is flatter. So the colors actually make it very easy for me to go over the topography with a patient. That, when I explain, especially keratoconus to a patient, and you see this big red, color on the map, you tell them that that is the place where your cornea or the front surface of the eye is not more rounded, it's more like this, it's more conical. So the colors actually help in explaining to the patient, and it also gives us an idea as to where the steeper areas in the corneas are, so we know how the lens behaves. So the central data in this map is more accurate than the peripheral, and this is an ideal map for selecting base curve of corneal GPs and also of soft contact lenses. Now, the tangential map, which is the bottom left here and here, so that map, it measures the power or the curvature of the individual points. So this does more individual, and then axial does, more like a panoramic view. Now, this tangential map is more ideal for ortho-K, so you will be able to see the specific pattern that we're looking for, like a bullseye or a central island or whatever pattern that, that changes the corneal curvature based on the fit of the ortho-K lens. You'll be able to use that map for this reason. And then you can also see the change elsewhere. And then the corneal thickness or relative pachymetry, which is the middle measurements here, okay, that you get in the topographer. That is a thickness measurement of the cornea up to 9 millimeters again. Warmer colors means it is thinner, and then cooler colors means it is thicker, okay? So this is ideal for monitoring, scleral contact lens wearers because you want to measure the thickness of the cornea on patients who have been wearing scleral lenses for a while, because there is some research showing that about 4% of post-surgical eyes can develop, stromal edema, and I have gotten into the habit of actually doing that on all my contact lens patients, who are wearing scleral lenses. So whether be it for pellucid or keratoconus or even dry eye, and then the run-in-the-mill dry eye, and then post-PKP patients, anybody on whom I'm fitting scleral lenses, whenever they come back for a scleral lens check after finalizing the first contact lens pair, be it 3 months, 6 months, or a year, I check eye pressures, and I also do pachymetry on them, okay? So I want to see if I'm making any changes to their cornea because of the scleral lens wear. And then the elevation map, which is the last one. So this is on the right side, the front, and then the back. So this is a map that shows the difference between the examined anterior and posterior corneal surface, and there is a standard reference shape of 8 millimeter best fit sphere or best fit toric ellipsoid. And here the warmer colors means these are the areas above, and cooler colors is areas below. Now, a difference in corneal elevation between the highest and the lowest point of elevation, if it is greater than 325 microns, it'll be of the lens. So you have to fit them in a scleral lens so it vaults over the cornea. So what that means is, if there is a significant difference between the pachymetry readings from highest to the lowest point, okay, like you see in a keratoconic, if it is a very advanced keratoconic patient, then you will know that the cone is so much steeper that if you just fit them in a gas permeable lens, the lens might have an edge stand off, and so it may not be stable. So you will have to fit a larger scleral lens that vaults over the cornea. Okay, so now that we have gone over the PenCam, what to look for, and what each of these maps mean, So this is how this gentleman's topography looks like. Okay, so there is a vertical bow tie, which means it's with the holistic medicine. If it is a horizontal bow tie, it is against its flatter curvature, and then tangential is more dioptric measurement in of each points individually, and then that is used more for corneal topography. I lost my mouse. There it is. Okay, so this is more used for orthokeratology and also to look for signs of warpage. And then these are the corneal thickness and relative pachymetry measurements. Okay, that's here. And then this is the elevation of the front and elevation back. Now, the main area where when I look at the elevation is more so than for every patient is when you have a form-fruste keratoconic patient. In a form-fruste keratoconic patient, you will actually see that there is some form of posterior elevation that is starting to happen, especially when you know that it is an asymmetrical condition. Keratoconic patients are usually bilateral, but they're asymmetric. So one eye might have a very advanced cone, but then the other eye might not show any signs of keratoconus clinically when you're seeing the patient behind the slit lamp. But when you do a topography on them, mainly on the posterior side, even before it shows up in the anterior side. So I have actually picked up a lot of form-fruste keratoconus by doing this topography and seeing the elevation map. Okay, so bitoric contact lens design. So what are bitoric contact lenses? They actually have 2 front and 2 back surface curves, and then they're mostly utilized when the corneal sill is equal to or greater than 2.5 diopters. Now, it uses a saddle principle to maintain the stability. So the lenses have to be stable to give the best vision possible, right? And that's one of the main reasons why, we are fitting these lenses, because in soft toric contact lenses, because they drape on the eye, and even if there is a little movement, even though you might have stabilization methods for soft lenses, if you have a very high astigmat, even if the lens rotates and their vision is not as clear and stable. So that's when we use a toric contact lens design in a hard lens. Okay, so it could be a front surface toric, a back surface toric, or a bitoric. So when the bitoric contact lenses are used, so they are based on the saddle principle. So there is full alignment of the 2 principal meridians trying to eliminate the corneal sill. So there are 2 fit types, spherical power effect and then cylinder power effect. So spherical power effect is when the lens actually optically acts as a spherical lens, because the difference in the base curves between the front and the back surfaces, they cancel out the toricity, okay, regardless of the rotation. So it acts as a spherical lens, okay, because it cancels out the toricity, the base curves of the front surface and the back surface. Now, in a cylinder power effect, the front and back base curves do not completely equal the difference of the lens powers. So the rotation plays a factor. So these lenses have to be stabilized, so usually prism ballasted. So they are prism ballasted, so the lenses don't rotate, so they have more stability to them. If we have to talk about the optics of toric contact lenses and how a front surface toric works, or back surface toric works, or even a bitoric for the spherical power and the cylinder power effect, that in itself is a 1-hour lecture. So basically, spherical power effect lens acts as a spherical lens because the difference in base curves between the front and the back surface, they cancel out the corneal toricity, and then the cylinder power effect, they do not, and then so they have to be prism ballasted basically. Okay, so what are the most common bitoric fitting guide is the Mandel-Moore, and you can get that information from the GPLI website. Okay, so GPLI stands for Gas Permeable Lens Institute. So they are made of all the gas permeable contact lens manufacturers in the US, and so they maintain the website. And Dr. Ed Bennett, who has written a lot of books on contact lenses and articles on contact lenses, is the executive director of GPLI. So they have a lot of resources for practitioners and for students, and they actually have the Mandel-Moore bitoric fitting guide in the website itself. So all you have to do is just plug in the numbers, and then it'll tell you what lens you need to order for the patient. So it's very easy. It's like a software, where you just plug in the numbers and it'll tell you the final lens that needs to be ordered. So based on the Mandel-Moore bitoric fitting guide, for what it says, to be able to order a bitoric lens is you have to flatten the flat K by about a quarter diopter, and then flatten the steep K by half or 3/4 of the diopter, depending on corneal sill. Okay, and then you make power adjustments to the lenses accordingly after vertexing the spectacle prescription. Okay, so that is always the most important thing. So you will plug in the numbers, and then it'll be vertexed, and then the final lens is actually given, in a box, and then you will actually talk to the consultant and then just order the lens. Or you can just, like what we do usually, is to just call the company and then talk to the consultant, give the measurements, and then they will design the lens for you. Okay, so basically with the Mandel-Moore, there is a bitoric lens fit factor based on corneal cylinder. So that varies from about 2 diopters to about 5 diopters. So based on the amount of corneal sill, you will have to either fit the flat meridian on K or flatter, and then the steep meridian is always fit flatter, about 0.5 to 0.75. Okay, so again, it is based on corneal cylinder. 2 diopters to 5 diopters or more, flat K is adjusted, and the steep meridian is also adjusted. Okay, now what is the ART optical bitoric fitting guide? So the initial selection, the flat K is fit on K, and then the steep K is fit 1 diopter flatter. There's no power adjustments made after vertexing the spectacle RX. So what that means is you are vertexing the spectacle prescription, but then even though you are fitting the steep K 1 diopter flatter, they don't apply the SAM-FAP rule. They just keep the same power of the lens, and then per consultants, that has worked the best for them. So they follow a bitoric fitting guide, and their software, in their software, they do not make any adjustments for flattening the steep meridian, and they just do the vertexing of the spectacle prescription and order the lenses. Okay, so here we are. So this is the picture of the contact lenses in the patient side, the second lens that I ordered. So the first lens, which was not as stable per patient, where the vision was coming and going, we steepened the base curve by quarter diopter, and then we increased the diameter from a 9.3 to a 9.5. So this is what the lens looked like before blink in the left, and then after blink on the right. Okay. You can tell that, there is probably a little bit of fluorescein, here. So that could probably cause the patient to not be as comfortable with the lens. This is the right eye. And then as you can see here in the left eye, this is before blink and this is after blink. So after blink in the left eye looks much more even or uniform, but not as much of a sodium fluorescein, underneath the lens, as you can see in the right. Okay. So with this lens, again, the vision, was 20/100 and about 20/50. Even though the vision in the left eye could be better as he probably wore the lens, he just decided to continue wearing his current custom soft toric contacts just because of comfort, even though his vision was better. Okay. So you might have patients like this as well, even though a little bit better than what they came in with. So if you ask me, with a soft toric contact lens in his left eye, he was only about 20/70 or 20/80. But then with a gas permeable bitoric lens design, he was about 20/40 to 20/50. But because he was not as comfortable, and the comfort was such a main issue for him, because all along his life, he's 36 years old and he's never worn hard lenses. And he has been a progressive degenerative myope all his life, always worn soft. So for him to make the switch from a soft lens to a hard lens was difficult, was harder. So he lose the lens, and then he might have to pay more money to order another set of custom soft toric contacts. So the other factor also is, even though he was referred to be fitted in a hard lens, the astigmatism, as we saw, it is not more limbus to limbus, and usually a bitoric lens design probably works, it actually works better on a limbus to limbus, more symmetric pattern of astigmatism, rather than for somebody who has more like incomplete or central astigmatism. Even though it's a lot, it's still not extending limbus to limbus. It's more, in the central area of the cornea. And again, the vision was still fluctuating with his soft toric contact lens. So he was referred back to low vision rehabilitation for acquiring a bioptic license to be able to drive. So bioptic, telescopes are used in the state of Tennessee on visually impaired patients to be able to drive. Not all states in the United States allow bioptic telescope driving. But if you have a patient who's legally blind, when I say legally blind, here the criteria is 2,200 for Social Security benefits, and so they have to be at least 2,200 in one eye. Okay, so the best corrected vision is 2,200. Okay, so that is, they can be 2,400, and so they have to be 2,200 in each eye. And then whichever eye is their stronger eye, or if they have 2,000 in one eye and 2,200 in the other, the bioptic telescope is fitted on the 2,000 eye, so they can still drive. Okay, so there is a visual field requirement as well. So when you have a patient who needs to be qualified for bioptic driving, they have to have at least 150 degrees horizontal visual field diameter. That is, from this extreme to this extreme, they have to have at least 150 degrees. Okay, so when you do a Goldman perimetry on these patients, if they do not have that, they do not qualify. So sometimes we have patients who qualify for vision, but then they don't qualify for visual field. And then the other scenario also happens where they can qualify for visual field, but they don't qualify for vision. So for that reason, he continued to, he decided to stay with custom soft toric contacts and then with monocular handheld telescope to use as need be, because he could not drive, because he did not qualify for the visual field requirement for bioptic telescope. And with the custom soft toric contact lenses, his best corrected vision was in the 20/70, 20/80 range in the left eye. So in Tennessee, to be able to drive, best corrected vision in one eye has to be 20/40. Okay, so there is a possibility that if he had worn the gas lenses, he could have achieved that, but then, he was like, I'm not comfortable, I'm not motivated, I cannot spend a lot of money, so let me just continue with what I have. So what's special about this case? We as contact lens practitioners always want to give the best for the patient, to give them the best visual potential. What we think is the best might not always be the best for the patient, and then even though we have educated the patient enough, sometimes we have to just go with what they're comfortable with. At the end of the day, they're the ones who are going to wear the lenses, and they're the ones who are going to pay for the lenses. So, patient satisfaction, patient motivation, they're all extremely important key factors to be able to try these lenses. Now, the other thing is we could have designed the lens in clinic itself, okay, using the Mandel-Moore bitoric fitting guide from the GPLI website. We could have designed the lens. Maybe if we had designed the lens that way, in addition to making the changes to the lenses that were already ordered by, through Art Optical, if we had changed the design of that lens based on Mandel-Moore fitting guide, which actually said a little different, in base curve measurements and also in powers for both the right and the left, maybe the patient would have been motivated. So this is again another lesson learned. So when you have a patient with corneal astigmatism, you could design the lens yourself using these resources, and then see if your empirically ordered contact lens, if it's not working well, if you are able to design to have the best vision possible. So those were my lessons learned. Okay, so not always do the empirical lens designs work great, and not all the fittings that you do are successful, though I thought the patient would be benefiting from a bunch of soft toric contact lenses. Okay, going to my next case. So this is a gas permeable multifocal contact lens patient. So this is a 67-year-old Indian male who was interested in trying multifocal contact lenses. He's an established gas permeable contact lens wearer of unknown parameters because he was fit by an outside provider. So vision with the current monovision gas permeable contact lenses, was 20/25 binoc and 0.63 m binoc. So whenever we do bifocal contact lens fittings, whether be it monovision, modified monovision, or bifocal contact lenses in both eyes, you always want to check vision binocularly because that is how they function. Okay. So monovision correction is when one eye is corrected for distance and the other eye is corrected for near. So there is always a gap. There is this zone that the patients might not be able to see very well. Okay. And that is the major downside of monovision contact lens wearers. And sometimes their depth perception could be off, but I also have, our hospital staff, nurses who wear monovision who do great, okay? I'm always iffy about fitting monovision contact lenses on somebody who uses sharp instruments, just because their depth perception might be off. And I also always educate my monovision contact lens wearers about nighttime driving, where it might be a lot more glare and halos of oncoming headlights when compared to bifocal contact lens wearers in both eyes. So that is monovision. There's something called modified monovision, where one eye is corrected either for distance or for near, and then the other eye actually is corrected with a bifocal contact lens. Okay, so if you have a patient who's probably a truck driver, who needs more distance vision, and then to be able to see the odometer, they would benefit from being fitted in a distance contact lens in one eye and then a bifocal contact lens in the other eye. So they will be able to use both eyes for distance and then just the bifocal contact lens eye for reading. Now, the same thing can be done with somebody who does a lot of paperwork or computer work, where one eye could be corrected for intermediate or near, and then the other eye could have the bifocal contact lens. So they will still be able to see distance with the bifocal contact lens eye. And then the other eye is more for intermediate or near viewing distance. And then you can also do two bifocal contact lenses, okay? So whenever a patient comes to our clinic to be fit in bifocal contact lenses or any of the other modalities, you always want to check for eye dominance. So how do I do in the clinic? The simplest, easiest method is the triangle method, where you ask the patient to actually extend their arms and then create a triangle, okay? This is somewhat of a triangle, and then have them look at a decently large letter, okay? So say 2050 or 2060 letter, by extending their arms, and then have them bring their arms close to their face, okay? So by doing so, they automatically bring their arms close to the eye that is dominant, okay? That is a triangle method. There is a hole in the card method, which works the same way. So you actually create a hole, a decent size hole in a card, and then hand them the card, and then with their best corrected distance vision, you have them look at a distant letter and then have them bring the card close to their face, and then they will automatically bring the card close to their dominant eye, whether it be the right eye or the left eye. The other methods that are also, practiced, some of the practitioners swear by the plus lens blur method or the sensory method, where you actually add a plus lens of +1 or +150 in each eye with their best corrected distance vision, and have them tell you in front of which eye, when they place the plus lens, they are having the least blur, okay? Or the most blur. Either way, it works, okay? So say I am right eye dominant. So when, with my best corrected distance vision, when I hold a +1 or 125 or 150 lens in front of my right eye, my distance might seem completely washed out. While if I hold that plus lens in front of my non-dominant eye, which is my left eye, I might still be able to see pretty good because I'm using my dominant right eye to be able to see. So in that case, my right eye is my dominant eye, and then my left eye is my non-dominant eye. So that is the sensory or the plus lens blur method, or you can do the triangle or the hole in the card method. So that's how you check for eye dominance. So this patient, when he came cylinder form of the refraction, so -875 +50, so pretty high myope, not as high as the first guy, who was almost 20 diopters nearsighted prescription. So with the right eye, he was 20/20, the left eye, 20/30. As you can see, the left eye is a lot more myopic than the right. And then with the add of 250, he was able to see 20/20. Now, this is the Penacam of the patient that was done in 2019. So as you can see, this is the right eye, and then this is the left eye. So this is the axial, sagittal, axial or sagittal, and then this is the tangential, and then corneal thickness, relative pachymetry, and then the elevation on the front and in the back. So this shows about 1 diopter with the rule astigmatism, even though it's not very regular as the previous patient, and then with a mean K of 42.45. And then the left eye, so slightly irregular, almost looks like, oh my God, does this patient have a cone? Not necessarily, because, he also wears gas permeable contact lenses, and has been wearing gas permeable contact lenses for a long, long time. And so you can see, it's not a true cone, but then there's slight irregular astigmatism of about a diopter with a mean K of 4171 diopters. So again, for this patient, we empirically ordered, okay, so because we see about 11 to 12 patients in a half a day session, we do not have much time to be able to do diagnostic contact lens fitting. And if it is a specialty contact lens, unless or otherwise, it is a hybrid lens or a scleral lens, with the gas permeable lenses, if it is an aphakic contact lens or a keratoconic who needs a gas permeable contact lens, we actually tend to we tend to do the fitting with diagnostic lenses. Otherwise, we just use the empirical fitting method. So multifocal contact lenses that were ordered, empirical fitting, the right eye, so again, optimum comfort is the material of choice because it has a high decay, and then it is easier to it's not as hard as the older gas permeable lens materials that are so hard, and so this one is a little more pliable. And then, so the multifocal lens design was renovation multifocal, and then those were the parameters. And then again, the right lens is green with dot, and then the left lens is the parameters, and then blue. Okay. Do we need to consider best corrected vision antimetropia if patient has, while prescribing combination of monofocal on one eye and multifocals on other? So when you say antimetropia, I'm thinking one eye is nearsighted and then the other eye is farsighted, right? They have inherent monovision. So usually I don't tend to fit those patients in contact lenses at all unless they want the nearsighted eye to be for distance as well. See, that's what you're trying to achieve when you give them bifocal contact lenses, to be able to see at distance and close up. But if they are already having farsightedness in one eye and nearsightedness in the other eye, the far-sighted eye, depending on the prescription, because sometimes I might just have a plus 50 or a plus 75 and they're still about 20/30 or so. I always say 20 happy. I do not aim for 20/20. And that's another thing that I also tell my residents. If my patient is 20 happy, I am not going to be pushing them to be 20/15 or 20/10. Okay. Because sometimes it is not realistically possible. So if the far-sighted prescription is pretty significant, okay, then I might actually put a contact lens in that eye, for them to be able to see better at distance. But then the near eye, depending on their age, if they are comfortable doing their computer work and reading, I may not fit them in a contact lens at all. So hope that helps. Okay. So for this guy at the dispense appointment, vision with both lenses was 20/20 binocularly and 0.5 binocularly at near. And then he was also happy with his computer vision. So that's another thing that I do with my patients when they come in for multifocal contact lens fits. So you always want to check binoc distance, reading, most importantly, their phone, because that's what they want to be able to see, or their iPad. And sometimes patients come with their laptops because they're coming from work. Okay, so I want them to look at their laptop. So it may not necessarily be at arm's length distance. They might be having it on their lap. So it is somewhere in between near and arm's length distance. So I have them sit in my chair looking at the desktop as well, so they can see how their vision is with the contacts. Sometimes, their distance vision might not be that great, but if they are able to see their computer, great, they are extremely motivated because that's what they do day in and day out. So that's why I check all distances before I let them go with the lenses, just so they know what to expect. So there is some motivation to be able to try these lenses, even if their vision is not completely crisp. Okay. So the fit assessment of these lenses, there was uniform sodium fluorescein clearance, like how you want it to be, with adequate movement and good centration. At follow-up appointment in 3 weeks, VA was still stable at distance and at near. He still continues to wear these lenses for 2 years. So I actually have not seen him yet. He usually comes to me either during Thanksgiving, which happens in the 3rd week of November, or during Christmas, because he is a faculty at the Vanderbilt University, at Vanderbilt University. So he teaches, he's in the engineering school teaching physics. So in 2021, when he came back, he was diagnosed with having a giant papillary conjunctivitis in both eyes. And when he came for his yearly contact lens exam, and he said that he was not very comfortable with the lenses. So I flipped his lids, found out he had GPC, had to be treated. So we're going to go over that as well. So this is the multifocal contact lens that I fit on this patient. So this is this is called the renovation multifocal design, which is again manufactured by Art Optical. And this is, they use a calculator, to design this particular lens based on topography and, prescription of the patient. So on a spherical base curve, this lens is fit on K or slightly steeper than flat K, depending on corneal sill. Okay. So most of the aspheric bifocal or multifocal contact lenses, I should say aspheric contacts, that is for bifocal wearers, is fit either a diopter or diopter and a half steeper than K, just because of the way they need to be sitting to be able to give the best near vision possible. Okay. And older patients, older presbyopes, like, this guy, who's in his 60s, who already has about a two quarters or 250 bifocal ad prescription. They do much better with the center distance aspheric lens design because of the positive spherical aberration, that is augmented by these contact lenses, these aspheric contact lenses. When we talk about gas permeable multifocal contact lenses, there are two categories. Okay, so one of them is the alternating or translating design, and then the other one is the simultaneous or aspheric or zonular or annular or the extended depth of focus. So all of them come under simultaneous lens design. And then alternating or translating, designs are the lenses that actually have a line, physical line in their contact lens. Okay, so it is like wearing a cryptoc bifocal. Okay, so or the complete line segmented bifocal, as we call it. So when you're fitting patients with those lenses, you will still see, I still have a handful of patients who wear those lenses. The lower lid positioning is extremely important, for those patients. When you fit a bifocal contact lens wearer, the lower lid positioning, if it is at the lower limbus or above the lower limbus, then those patients can be fitted in the alternating or translating design. When I say translate, so what happens is there is a physical line in the contact lens itself. Okay, so they're looking at distance, and then when they look down, their lower lid actually pushes the lens up, so they're looking through the reading part of the lens. Okay, so that is a translating design or the alternating design. If the lower lid is under their limbus, like in my case, my lower lid is not touching my lower limbus when I look straight ahead. It is actually down. So I will be a very bad candidate for a simultaneous or an alternating lens design, because even when I look down, my translation might not be as high to be able to get into the reading portion of the lens. So I will do much better with an aspheric lens design or a simultaneous, bifocal contact lens design. So this is one such lens. Okay, so they have the distance or intermediate in the center, and then they have the near in the periphery of the lens. And so it has flexible front surface eccentricity that corrects for aberration, and then flexible distance and intermediate zone that ranges from about 3.5 to 4.25, but 3.95 is standard. And then automated thickness control, because that actually makes sure that the lens is centered better. And then there is also wearing comfort for higher ad powers. And this is specifically meant for mature presbyopes, especially more than 2.25 diopters of ad. So this is the Penacam in 2021. Okay, so compared to the Penacam in 2019, the topography really hasn't changed a whole lot. Maybe the right eye got about a 0.2 diopter flatter, and then the left eye got about a half diopter flatter. That's all. So there's no significant change in the topography of the patient between 2019 and 2021. So this is the slit lamp photo of the fluorescein pattern of the right lens, with the optimum comfort renovation multifocal in the right eye, green with dot, and then left eye, blue. So these are the parameters of the lenses, and then 9.5 diameter. So as you can see, the lens is actually sitting pretty good. His lower lid is slightly below the lower limbus, and so and because he was very particular about being able to see his computer screen, and then you can also get a translating design that is a trifocal. So you can have two lines in the gas permeable lens also. So fitting those lenses, you have to be extremely accurate, because you need to know how the lens is sitting in the eye to be able to make adjustments. And those lenses are usually prism ballasted, so they will be more stable, or they're truncated, so they're more stable. Truncated is when they take up a small bottom portion of the lens, so it almost looks like somebody cut the lens out in a little, so a little arc of the lens is actually cut. So that actually maintains the stability of the lens, because it does not touch the lower lid anymore. So this is the right, so uniform, pattern, and then here is the left. If you can see the left, it probably has a little more fluorescein right about here. And then I was shining a bright light, so he was trying to close his eye more, and so that's why it's not as wide open as his other eye. So this is the slit lamp photo of the GPC that he had, under the upper lid in the right eye, and then in the left eye. So as you can see here, let's see. So the bumps are a little more prominent here. So they tend to reflect a lot of, light because they're inflamed. So my pet peeve, right from my optometry school in India, is to avert upper lids on all my contact lens patients. Okay, so it doesn't matter whether they're wearing soft or hard or hybrid or scleral or whatever. All my contact lens patients will have their lids flipped. And I'm very well known for that, just because, you might have a patient who's saying all the right things to you as though they're very compliant, but when you actually flip their lids, it is a completely different story. Okay. So to be able to determine a problem with a contact lens patient, and also to educate the patients on their wearing schedule or compliance, you have to be more thorough in their ocular health examination. So flip their lower lid and then flip their upper lid, make sure everything looks good. Okay. Now, this guy actually came in saying he is not very comfortable with the lenses. And so I had to flip his lids. I was going to do it anyway, but then because he said it, then it is more imperative for me to flip the lid. Sometimes you can detect foreign body. So I have actually had a patient who had a lash underneath his upper lid, and then it was almost, almost stuck. And so when he was wearing his contact lens, he would not feel anything. But then, when he took the contact lens out, he would have a foreign body. But that patient didn't wait 1 year to come and see me. I saw that patient within about 10 days. And so I had to just use the forceps and then just take the, lash out underneath his upper lid. So, he had decreased comfort because of the GPC, and then right eye more than the left. And so we had to discharge contact lens wear or discontinue contact lens wear and have him wear his glasses. So that is another pet peeve of mine. Even my keratoconics will have some glasses prescription to be able to function. You're better off seeing at least somebody is there rather than not seeing anything at all. So some doctors might feel like it is such a waste of money to give glasses prescription for a keratoconic just because, their vision with glasses is not as good. But my thinking is, when you're not able to wear a contact lens, you are so blinded that you cannot see anything from here on. If I give them glasses, at least they are able to see the things, even though it is not very clear, even though it may not be crisp. At least they know that there is something that they need to be aware of. So all my contact lens patients will have some form of spectacle prescription. And when I dispense it, I also tell them that, the vision, of course, with your contact lens is going to be so much better than with the glasses. So we prescribe Lotamax for the patient. So of course we have, prescription privileges here. So we cannot give injections in the eye as in, in the outside, not inside. But then, for chalazion, we are allowed to give injection, but not anything in the globe itself. So prescription privileges also change from one state to another in the US. So we are allowed to give prescriptions for glaucoma, and then also steroid, and then our oral, prescription in Tennessee is also pretty good. So loteprednol, etopenate 0.5%, that is Lotamax, that is the trade name. Okay, so we prescribed that 4 times a day for 2 weeks and then twice a day for 2 weeks. At 1 month follow-up, patient was doing much better. I decreased the Lotamax to every day for 2 weeks again. Because he is an avid and very vigorous, contact lens wearer, it's very hard for him to be not wearing his contact lenses just because of the nearsighted prescription that he has. And he's a busy man, he travels a lot. And so he would much rather be seen with contact lenses than with glasses. So of course, I want to treat it very hard so it doesn't come back. So that's why he's been on Lotamax for this long a period of time. So the only thing is you have to make sure that you check the pressure of the patient's eyes whenever they wear their steroid, whenever they use steroid drops. So we monitored the pressure. The giant papillary conjunctivitis had resolved. So this is the other thing that I tell patients about GPC. It never completely goes away. It is not as bumpy as it used to be. So the papillae, are not as rounded and inflamed. They are just more flat. That's all. And then it does not look as red as it will do, if it is inflamed. And that patient's still comfortable with his contact lens wear. 2 years later, patient is still happy, but he has slightly decreased vision. As you saw, he's, let's see, I forgot, he's in his 60s. So he's a 67-year-old guy, and then he did have some cataracts. So, the next stage is probably for him to go and have his cataracts removed. And knowing him, he probably will, wear, or I guess he will opt for the premium IOLs, so he doesn't have to wear contacts or glasses after cataract surgery. So he'll be able to see distance, close up, and also read with. Okay, so that's that case. And so what is special about this guy? Okay, because he was wearing monovision gas permeable contact lens, already, switching him to the bifocal contact lenses was a very easy transition. And given that he was able to see good at computer, so motivation again, and then the vision success that he was able to see in office motivated this patient to continue wearing the bifocal contact lenses. And lid positioning, as we discussed, for a simultaneous design, or an aspheric lens design, lid positioning, so it's more an interpalpebral fit. So the lower lid will be lower than the lower limbus. And then if you are thinking about the translating design, then the lower lid has to be at the lower limbus or above it, so it can translate very well. So you should know, these criteria before you fit bifocal contact lenses, because you want to look at the patient, patient's eye, the lid positioning, and then what is their expectation, and also what is the use, of these lenses. All my bifocal contact lens wearers will also have this spiel from me. Your vision with the bifocal contact lenses is not comparable to your progressive glasses. I tell it right off. So I am bringing their expectation down. Okay. If I am able to get you to be successful with these lenses 70 to 80% of the time, that's the best success, is what I tell them. For almost 25 years of doing this, that's what I tell them. And if they get 90%, they are elated. If you present at 90%, then, if it performs only at 80%, then they're not going to be happy. So always, downplay or give them realistic expectations. And if they do better, then you will be their most favorite eye doctor. So 70 to 80% is what I tell my patients. And then sometimes I have had patients who tell me, yeah, you're right. It's not as good as seeing with my glasses. Or they might say, this is an excellent thing. I'm so glad that you fit me in these lenses, because I can do everything with these lenses. And I have worn my glasses truly as backup, so the vision is so great with these that I do not have to depend on my glasses all the time like I used to. And always remember to avert the upper lids, to look for GPC or anything out of the ordinary in all contact lens wearers. And then having backup glasses is important. So when you give contact lens rest to these patients because of anything that they might have, they should have backup glasses so they can function. The most important thing I tell patients is, your backup glasses do not have to be changed every single year. Just make sure that you're still able to drive with them, because that is one of the main criteria. We do not have public transportation in the city that I live in. So you have to be able to drive, and to be able to drive, you have to be able to see. To be able to see, you should either have your glasses prescription or your contact lens prescription. So when you're not able to wear your contacts because of, say, flu or COVID or fever or something going on with your eye, like an abrasion or an ulcer, infiltrate, GPC, whatever it might be, you have to have backup glasses that you can still drive with. Okay, so that's my gas permeable multifocal contact lens patient who's special in a way that, he has been successful. Of course, this is a lecture that I'm giving about my interesting contact lens cases. I have had my fair share of failures as well, just like the first patient, the bitoric patient who continues to wear his soft rather than the hard lens that I have prescribed for him or that I had fit him in. Okay, this is a hybrid patient now. So a 29-year-old African-American male was diagnosed with keratoconus in both eyes, right eye more than the left. Okay, so since he was 19 years old, he has a history of PKP, penetrating keratoplasty. So he's had a corneal transplant in the right eye for advanced keratoconus in early 2014. Basketball injury in the right eye happened and caused prolapsed ocular tissue. So he's blind in that eye. So he's NLP since 2014. So that is the, when you have a monocular patient, the most important thing is monocular precaution. So they have to have polycarbonate glasses that they have to wear, or I guess polycarbonate lenses in their spectacle prescription, so they can protect their one good seeing eye. Okay. So that is something that we always do with any patient who's monocular or who has only one good seeing eye. Say the other eye is 2200, and then one eye is 2040. Then those patients, when we give them prescription glasses, it always says polycarbonate lenses on them. So you want impact resistant lenses. Now, his manifest refraction on the day he saw us, right eye, of course, it's NLP, it's all jagged up. Okay, so he doesn't use his eye at all. The left eye is about -19, and it was still 2400. So we did a hybrid contact lens fitting on him in 2015, and this was the lens that he was fitted in that was finally ordered for him. The synergized clear cone with a vault of 600, steep skirt, -17, 14.5 diameter, and with that lens he was 20/40 -2, and that was his best corrected vision. So what is a clear cone lens? It is a hybrid lens manufactured by Synergize. Okay, so the parameters of the lens is in the upper right. So it is a reverse curved lens designed for decentered ectasia. So you have these many vaults available, okay, in the lens in 50 micron steps. And then you have skirt curves that is flat, medium, and then steep and steep 2. Lens powers also varied, and then material, that's the PSPHOO D center, that is the hard center, which is shown in this figure. So that is the hard center, and then there is a soft skirt. Okay, the soft skirt is hemiberylcon A, 27% water content. So as you can see, the decay of the center is 100. That's pretty good. Now, how do we examine this lens? So the first lens to choose from the diagnostic fitting set is the 250 medium Walt, and then the diameter is standard 14.5 of all hybrid lenses. Okay. Once you use the plunger, put the lens, and then fill it up all the way, almost to the point that it looks like a bubble. I guess it should be almost convex. Okay. And then, you use sodium fluorescein strip, and then make sure that the sodium fluorescein is, in the bowl. And then you have the patient look down parallel to the floor, and then you insert the lens. Okay. So preservative-free saline is extremely important. There are lots of studies about contact lens care, especially with scleral lenses that are, available in the market with what is the best that mimics the tear consistency. So you have so many preservative-free saline like that. So that's what you use. And then you examine the fluorescein pattern. Okay. So this is how the lens is, supposed to look, an ideal clear cone contact lens fit. 3 minutes after insertion. Okay, with scleral lenses, you let them sit in the office at least for 15 to 20 minutes before you assess the fit. But for a hybrid lens, you have to do it immediately. Otherwise, the fluorescein will go. Because these lenses are supposed to move a little bit with blink. Okay, so there is constant tear exchange. So the sodium fluorescein will come out if you do not examine the lens immediately after insertion. Okay, so based on apical clearance, to clear the cone, you have to change the vault of the lens. Okay, so you do not want any real dark areas. Now, in this figure, even though it looks like it's a little darker, when you use the slit lamp with thin beam, or parallelepiped, you'll be able to see a little bit of tear layer underneath the lens. Okay, so even though it might look dark like this, you will be able to see fluorescein underneath. If that is the case, then that lens is actually a pretty good fit. Now, if you do not see any fluorescein underneath at all, then there's bearing. So then you will have to, change the vault. So you change it, by 100 microns, but then the final lens, the best fit is attained by adding 50 microns to the final lens order, just to make sure that you have adequate vault. Okay. So that is the vault of the lens. Now, the skirt evaluation, which is also done 3 minutes after insertion, you should have sodium fluorescein thinning in the inner landing zone and bearing in the outer landing zone. Okay, so what is inner landing zone? Inner landing zone is in the GP portion of the lens just before the junction. Okay, let's see. Okay, so inner landing zone is right about here, just before the junction, and then the outer landing zone is in the soft portion of the lens after the junction. Okay, so that's the area that you will look for to determine the skirt. Because they come in different skirt curvatures, you need to know which skirt actually works the best. Now, if both the areas are very dark, then the skirt is actually too flat, so you have to steepen the skirt. If both areas are filled with fluorescein, then the skirt is too steep, so you have to flatten the skirt. Okay. And then for the vault, if there is excessive vault, okay, then you need to decrease the vault. If there is bearing, then you need to increase the vault. Okay, so that's the basic fitting guide. Now, this is the penacam of the patient, I guess I should say serial, penacam reports that I have since I've seen this patient. So the last penacam was done in, end of 2014, and I saw him early 2015, and that's where the fitting was started in 2015 after he was seen by the corneal specialist. So that shows about almost 3.5 diopters of irregular astigmatism. Okay, as you can see. So this is the classic keratoconus pattern, as you can see here, in the tangential maps. 2014, and then let's see, this is blocked. That is 2017. Okay, and then there's 2018, and then this is 2022. Okay, so as you can see, the amount of astigmatism has changed from 3.5 to about 5.5 to again 4, and then to about almost 6 diopters. Okay, so the other thing that, whenever I have a keratoconic contact lens patient, the discussion that I also have is, if they have adequate thickness of the front surface of the eye, is to talk about the different options, for treatment, like corneal cross-linking. Okay, our corneal surgeons perform, epi-off corneal cross-linking. So that is, they do epithelial debridement and then they do the cross-linking procedure. So they have to have at least 400 microns of corneal thickness to be candidate for corneal cross-linking. Okay. Now, they don't do PKP unless or otherwise there is severe scarring. Okay, so I do have an advanced cone patient who's about 70 diopters in his corneal curvature. He is still successfully wearing his scleral lens. He does have a little bit of scarring, but his vision is about 20/30 or 20/40. So we are not going to touch it. Okay, so unless the apical scarring is so much that it starts affecting the vision and they are not able to see with a specialty contact lens, they do not do a PKP on a patient. Okay. So this is a slit-lamp photo of the fluorescein pattern of the left hybrid contact lens when the patient is looking up, and then the left contact lens when the patient is looking straight ahead. Okay, so you do not want any dark areas in the skirt, and you do not want too much fluorescein area in the area of the junction. Okay, so either in the inner landing zone or the outer landing zone. Now, this is something extremely important. If you don't take away anything, from this lecture, this is something that you will have to look into and learn about, just because, it keeps you abreast of what is available for keratoconic patients and how you can educate a contact lens patient if the condition has progressed or not. Okay, that is a constant question that I get from all my keratoconics. Okay, so Dr. Deepa, do you think that my keratoconus has actually progressed since the last time I saw you? So this is something that is available in the Oculus Pentacam corneal topography called the ABCD. Okay, so that is Bellin Ambrosio progression display. Okay, so Bellin and Ambrosio are both corneal specialists who came up with this nomogram to be able to monitor their keratoconics. Okay, so this is a great paper that you will have to read about. Okay, so it's called ABCD grading system. Okay, where the parameter A stands for anterior radius of curvature in the 3 millimeter zone. Parameter B is the posterior radius of curvature in the 3 millimeter zone. Parameter C is thinnest pachymetry in microns, and parameter D is the distance distance best corrected vision. Okay, so here is the stages. Okay, so when you print this report, it actually gives you A0 or A1 or A4, and it does so for each and every letter. Okay, so A, B, C, D. It's very easy to remember. So A is the anterior radius, P is the posterior radius, C is the thickness. Okay, so center thickness, and then D is distance best corrected vision. Okay, so as you can see, each of these letters with the stages, these are the numbers that they're looking at, and that's what the number corresponding to each of the alphabets mean, and that's the printout that you will get. And I do that, so you have to have at least 2 to be able to compare, right? So the first year I see a keratoconic patient, okay, so I don't get this. The second year I repeat the topography, I get this display that tells me what each of the numbers corresponding to the alphabets are. So then I know, if all the numbers stay the same, then it's probably not progressed. Now, progression of keratoconus requires a consistent change in at least 2 of the following, okay? Thinning, which is the C, steepening of the anterior K curvature, which is A, steepening of the posterior, which is B, and then increase in the rate at which perimetry is changing from the periphery to the thinnest point. So if I have a patient, keratoconic patient who's asking me, if their keratoconus has progressed or not, they have to have at least a consistent change of 2 of these parameters, okay? So if their A changes from 1 to 2 or 2 to 4, and their B changes from, 3 to 4 or 2 to 3, okay, but then the other 2 remain the same, they still have progressed. Okay, so that's the way to read this. Okay, and this is something that our corneal specialists also use to be able to do corneal cross-linking. So in the United States, corneal cross-linking is FDA approved for patients who show progression in their keratoconics, in their keratoconus. So our corneal specialists will do topography once, and then they'll have the patient come in 3 to 6 months and then repeat topography and then see if any of these have changed. Okay, if they have changed, then they say they are eligible for corneal cross-linking to be covered by insurance, and it is how the FDA has approved it. So this is a very neat little grading system that is extremely valuable for keratoconics. Okay, so please look into that at leisure. Okay, so based on the ABCD classification system in 2014, he was A4, okay, B2 to 3, and then C4 and D2. In 2022, he was A4, B4, C4, D2. So the only good thing going on for him is his vision with his hybrid contacts, okay? All the other parameters have they are at stage 4, meaning he's a pretty advanced keratoconus patient. So based on this, of course, thickness of the cornea is also very important to be able to be a candidate for cross-linking. He's not eligible because his thinnest pachymetry is about 300 microns, I think. So, so he won't be eligible. So his best bet is to continue wearing his contact lens to give him the best vision possible. So patient was last seen in August of 2022. He actually travels 2 hours to come to the appointment. That's why you see the gap, in the penacams. So one was done in 2014, and then the next one was not done until 2017. Okay, so he comes when he can, because he's also monocular, and then he has to depend on somebody to drive. Even though his vision is 20/40, he still can drive. But I have just told him to drive only locally and not interstate, because he travels 2 hours to come to see us. He's happy with his current hybrid contact. And then we had also talked about switching him to sclerals to help with the cost, because hybrid lenses are a little bit more expensive than the scleral lens. The scleral lens, is good for 1 year. So you just pay for one lens. And if the condition doesn't progress, and if the lens is still in good condition, they can probably wear the same scleral lens for about 2 to 3 years. But he declined, so he's monitored yearly to about 2 years by the corneal specialist as well. So whenever he comes to see me, I see him first, and then I refer him to the corneal specialist. Because he travels 2 hours, we just try to combine the appointments whenever he shows up. So what's special about this case? If ain't broke, don't fix. So if he's happy with the hybrid, don't switch him to a scleral. And we had not even done a GP contact lens fit on him, just because he works in a place that can get dust in the eye, and then if he is supposed to wear protective goggles, but if he wears just a regular GP lens for keratoconus, there is a possibility that the lens can get displaced and then it can get lost. So we just went with the hybrid given his occupation, and because he is happy. You just need to make sure that he's more compliant. He has to, replace the lenses every 6 months. So hybrids are replaced every 6 months. You go over the care system and then make sure they're using preservative-free saline and not a contact lens solution, because I've had patients who use contact lens solution in the bowl of the lens to insert it. That's a big no-no. And then, he is wearing a clear cone, but then they have actually improved the design of the lenses. The newest one is called the Ultra Health, which is actually, even though I call it the newest, it's been there for a while now. That is one of the lenses that has been designed to be able to give better oxygen permeability to the cornea. So the soft skirt is a silicone hydrogel. So that also allows oxygen, so there is improvement in hybrid contact lens technology as well. Okay, but because he is happy with his current clear cone, we did not switch him to an Ultra Health. Now, and then greater the progression of an eye condition, the closer needs to be the follow-up of the eye condition. Even though this patient lives 2 hours away, technically I would have loved to see him every 6 months to make sure he's doing okay. But again, these patients, if they are having a problem, they are going to come no matter what. That's good thing about keratoconus. Okay, so if no news is good news. So if you do not hear from the patient, that means that they're doing well. You will definitely hear from them if they are not doing well. Okay, so I'm presuming he is doing well. I last saw him in 2022, I think, yes. And then he was doing okay. So I haven't seen him in 2023. Okay, so due to time, I think I have another 10 minutes. So I'm just going to go over the scleral and the prosthetic real quick, and then I want to at least have some time for questions. So this is a scleral lens patient who is a 76-year-old Caucasian female who was referred to the contact lens clinic in 2019 for scleral contact lens fitting by the, in the left eye by our oculoplastic specialist, because she underwent a left brow lid, Merkel cell carcinoma excision and extensive radiation that caused the dry eye. And then she had worn hard contact lenses many years back, okay? So vision with the current glasses in the right eye was 20/40 and left eye was 20/100. As you can imagine, because of the dryness, the surface was not very smooth. And so the vision was also not very good with the glasses. So interested in trying scleral lens to get the best visual potential and better comfort. Now, all these patients usually, when they are referred for dry eye, are already taking a bunch of drops, okay? So they're tired of using the drops, and then even with the drops, their vision is not very stable, so they'll come to our clinic to be fitted with a scleral lens, okay, as a therapeutic measure to help with comfort and also to give the best vision possible. So refraction on that day was -150 + 125 with a vision of 20/30 in the right, and then left eye was about -250, but then vision was not improvable beyond 20/70, and then add of 250. So this is the external photo of the patient with the Merkel cell carcinoma on the left upper lid brow area. So it is a rare and aggressive neuroendocrine malignancy of the skin. It is typically asymptomatic solitary nodules with pink, red, or violaceous coloring. Eyelids are the common sites, okay, with the incidence between 5 and 20% of all head and neck MCCs. So sentinel lymph node biopsy, okay, that is the appropriate method for detecting regional lymph node disease. A sentinel lymph node is actually the first lymph node in which the cancer cells are more likely to spread from the primary tumor, okay? So you have to do a biopsy to be able to know for sure, for detecting the disease. What are the different treatment options for this patient, for these patients? Okay, surgical excision, then radiation, and then chemo, and then they can also take, medications like the somatostatin analogs or the tyrosine kinase inhibitors. So this patient had a surgical excision and radiation, and then she was seen in our clinic after, she was put on some eye drops. Okay, so usually the most common ones that the patients come in, for dry eye purposes to be fit in scleral lenses, they have already been on Restasis, which is the cyclosporin, or Xiidra, which is the liftograst, twice a day. And sometimes they also use ointment at nighttime, okay? And then during the day also, they might have to use some preservative-free drops, for better comfort. So when patients use that many drops, they come to our clinic, their hope is to be able to get off the medication completely or wean them off the medication eventually, okay? So when I say medication, I mean dry eye medications. So this is the picture of her eye, just her naked eye with no contact lens. So as you can see, there is some dryness of the surface, so this is serial photography. And then this is the picture that I go with, so that shows the whorl staining, whorl pattern of staining, and then thickened eyelid margins, almost sparse lashes in the upper lid because of the surgery that she had, okay? So this is the cornea that we are dealing with, for which we are going to fit a scleral lens on. So we did a scleral lens fitting. The fitting set that we have in our clinic is, again, the Synergize company that makes the hybrid lenses. It's called the VS Scleral. So the first lens of choice as recommended by the manufacturer is the Synergize VS 3600, 3642 Plano, 84160. Okay, so all those numbers, they all mean something. 3600 is the bulge of the lens. 36 is the flat meridian, and then 42 is the steep meridian. And then Plano is the power of the lens. So all the trial lenses do not have any power. 8.4 is the base curve and 16 is the diameter. Okay. Now, so it has a toric periphery already. Okay. So they come in different numbers. Okay. So if you have a perfectly symmetrical sclera, then you will actually have a 36-36. That means that there is no difference in the scleral profile. Okay. And then you will see a hash. The hash is where the flat meridian is, okay? And then you always mention the hash in the order because sometimes you might have to incorporate front surface toric on these lenses. So that is another option available for these lenses. And these lenses are also available as a bifocal with a center near design, okay? But majority of our patients, they are fit in distance scleral lenses. And then we advise them to wear glasses on top for computer or for reading. So they still wear a progressive lens, or they might just wear distance and then have over-the-counter reading glasses. Okay. So what are you looking for in the fit of these lenses? Uniform sodium fluorescein clearance with no conjunctival blanching or impingement and good comfort. And then with a spherical over-refraction of plus 250, she was good to 2040. Okay. So with her current glasses, she was about 2000. And then with a negative 250, she was only about 2070. Now with the scleral lens, and then these lenses fit a lot flatter. That's why you always get a plus over refraction on these patients. Okay, so when they fit flatter, you're actually creating a negative tear lens, and so to compensate for that, they will accept more plus. Okay, so that's very common with these lens fits. So with the plus 250, she was 2040. So we ordered this lens, okay, with that power, with the same parameters of 3600 volt, and then flat meridian, steep meridian, base curve of 8.4, and then 16.0, okay? And then the hash was at 135. So that means the lens was sitting like this. So that's where the flat meridian is. So the steep meridian is 90 degrees away from it, which is this way, which is 45, okay? Insertion and removal training was performed when dispensing the contact lens. Scleral material was changed from Menacon Z, which is the most common material or the material of preference, okay, to Optimum Extreme with tangible hydropeg, okay, in 2021 due to poor wetting on the contact lens surface. So with dry eye patients, the one thing that I also constantly ask them to do is to clean their eyelid margins with OcuSoft lid scrubs, okay, at least twice a day. Soon after a warm compress, clean your eyelids. We want to make sure that your eyelids are healthy, so the oil that is coming out of your meibomian glands are not making the tear film more, irregular, and then causing poor wearing on the lens surface itself. So always clean the eyelids before putting the lens in, okay? And then the tangible HydraPeg, is something that that is also available from Conamac. Tangible Science is the company that actually makes a specific contact lens solution called Tangible Clean that you have the patients use if they have a tangible HydraPeg coating. And then Tangible Boost is boosting the surface of the lens, because this coating can actually peel off over a period of time. So I have also encountered that after about, like 3 or 4 months, the patients might say that the lens surface is not very good, and then I have them use the Tangible Boost, which is recommended to use actually once a month. Okay. So that replenishes the coating. Okay. So Tangible Science is the company that makes the Tangible Clean and the Tangible Boost. So whenever I dispense patients with Tangible HydraPeg coating, I have them use those solutions. So patient comfortably wearing the scleral lens with few changes in contact lens power, and then due to cataract changes, and then she's followed up every 3 to 6 months. You want to constantly monitor these patients also, to see how their dry eye treatment is. Have you decreased it, or are you having to increase it? How is the comfort of the lens as you wear the lenses more and more, because you're slowly increasing their wearing time, and then now they have worn the lenses for a couple of years. See how they're doing. So she finally had cataract surgery in July of 2022 and was refit in a scleral contact lens post-cataract surgery. She developed, posterior capsular opacification. So I actually saw her in 2023, so spring of this year, and then she had YAG caps, and then now her vision is about 2030 probably, more clearly. 2025, she can get 1 or 2 letters, okay? So as you can see, her vision has gotten better, and then she has also gotten better with insertion of these lenses. That is also another important criteria to think about. When you have older patients who are not very stable in their hands, you will have to figure out ways of being able to teach them how to insert these lenses, with some help. Okay, there are lots of contraptions that are now available that are cheaper to help these patients be able to insert these lenses. So this is the Benegam of the patient, serial topography that was done in 2019, and then 2021, 22, and then 2023 when I saw her after cataract surgery. And then this Benegam is actually before she had the YAG caps. Okay. So as you can see, the PACI, has changed from 543 in 2019 to 531, and then 531 again, and then 546. So it's kind of remained about the same. So the reason I, do topography and also check their PACI is for any signs of edema. If my vault is too much, there is a possibility that I can induce corneal edema, and I don't want to do that on these patients when their cornea is already compromised because of dryness. So you want to measure their PACI to make sure that nothing out of the ordinary happens. Even though that is most common in post-surgical eyes, I do it on all my scleral lens patients. Okay, so the synergized VS design. So what is special about this? So this is how the lens looks. Okay, as you can see, this is the vault, and then this is the flat, and then this is the steep. And then so that has toric peripheries, and then these are all the different parameters that these lenses are available in. So 3,000 to 4,600, and then 28 to 50, and then these are the base curves. Diameter ranges from 14 to 17.5, power -25 to +25, also in multifocal, either Metacon Z or Conamax Optimum Extreme. And then you can have the tangible HydraPeg. You could have aberration control. So when I have a keratoconic patient, I usually add higher order aberration to the lenses already, and it comes at no cost for them. And then there's something called a limbal clearance factor, step 1 and step 2. So the limbal clearance factor is mainly used for patients who have an oblate cornea rather than a prolate cornea. So when they have an oblate cornea, when you fit them in a lens, just in the limbal area, you may not have enough clearance, but everywhere else it looks fine. So you could actually just add a limbal clearance factor that gives them about 25 microns. And then if you do step 2, you add 50 microns of clearance in the limbal area. So it has a diced, so after, going through all of the parameters, okay, so we're going to still, make adjustments to the contact lens parameters based on the sagittal depth, which is the vault of the lens, limbal clearance, and scleral landing zone. After 15 to 20 minutes of the lens sitting in the eye, you check for apical clearance, about 200 microns after settling, limbal clearance of 100 microns. The SLZ, that is the scleral landing zone, has to have edge alignment without conjunctival blanching or impingement. The one most important lesson I have learned while doing scleral lens fits is to actually paint take a fluorescein strip, wet it with saline, and then paint the surface of the fluorescein surface of the contact lens with the fluorescein. Okay, have them blink a couple of times and then use the blue light to see if there is any uptake of fluorescein underneath. Okay, so that tells me that the scleral landing zone is flat. Now, a steep scleral landing zone is very easy to see because it causes conjunctival impingement or blanching in that area. But if it is flat, you are supposed to look for a shadow, but I'm very bad at looking for shadows. I cannot see it. So what I do on every scleral lens patient, after the lens has settled, I go in, paint the surface of the lens with the fluorescein, have them blink a couple of times, see if there is any uptake of fluorescein underneath, and you will see the bright yellow in certain areas. So if it is where the hash is, that means the flat meridian needs to be steepened, and you can go in two steps is what it's called. Okay, so from a 36, it goes to a 40. Okay. So each of that is a certain micron that you are actually adding in, okay, to make it more well opposed to the sclera. And then, so if it is 90 degrees away from the flat, then the steep meridian needs to be steepened a little bit in 2 steps, okay? So this is a slit lamp photo of the fluorescein pattern of the left eye, scleral showing uniform clearance. And then this is, so the other important thing when you're doing scleral lens fits is to know the thickness of the lens. Now, all these diagnostic VS scleral lenses are 350 microns, okay, because they're plano power. Only when you incorporate power, the thickness of the lens changes. So you compare the thickness of the lens to the thickness of the tear film, okay? So then you know how much clearance there is. So if it is a 1-to-1, so it is 350 micron center thickness of the plano lens. So, and if we have the same thickness of the tear layer, then you know it is 350 microns, okay? So you want about 200 to 300 microns of the tear layer, okay, or of the vault, to make sure that the lens, doesn't sit too high from the cornea or too close to the cornea either, okay. And then in the limbal area, you want about 50 to 100 microns. And again, you'll be able to do that only by comparing the thickness of the lens to the tear layer, okay. Now, if you have the anterior seg OCT, then you will be able to, use the measures, the calipers, to know the thickness of the lens, and also to know the thickness of the tear layer. If not, we do not use anterior seg OCT, because we have so many patients to see. I just compare the thickness of the lens that comes in the box. If it has, 250, it's probably about 400 to 420 micron center thickness. I compare the tear layer thickness to that. So the CLEAR report, which is the contact lens evidence-based academic reports, is a consortium of, so many researchers, and they have put together so many reports on different kinds of lenses. So the scleral lens paper is fantastic. So they had actually done, that report gives you a lot of information about, either the anatomy and physiology of the cornea, of, gas permeable lenses, bifocal contact lens designs, and then the newest technologies and contact lenses that are available. So the research that is in that paper actually shows that, scleral lenses can be used for medical reasons, therapeutic reasons, to help the dry eye patients. And so it has significantly, increased corneal sensation, and then it has increased comfort on these patients. There's a significant improvement in their quality of life, and that's the reason we do this. This is a 59-year-old Indian male who was referred to our contact lens clinic for prosthetic contact lens fitting of the right eye after open globe. He had never worn contacts before. He wanted a contact lens that he could see out of to be more peripherally aware, and to also improve cosmesis by masking his corneal scarring. Entering vision in the right eye was hand motion, and then in the left eye was 20/30. So his good eye is the left eye, which is 20/30. And then refraction, just a little bit of minus with a little astigmatism, he was 20/20. And then so we did the fitting in 2016, and then he continues to wear the lens till now, 2023, and then he's also aware of monocular precautions. So this is the picture of the patient's right eye. Okay, as you can see, he has an inferiorly displaced pupil with extensive corneal scarring and neovascularization in the bottom. And then this is the Penacam, which is actually not very reliable at all because he was extremely light sensitive. Okay, and so I just showed it because we did it. We did try doing it, but then it was not very successful. And then this is the contact lens that we fit the patient in. Okay, so we have what is called the BioColors contact lens fitting set for prosthetic contact lenses for prosthetic contact lens fitting. This is something that we use in our clinic. There is one more called Alden that we use. That company actually makes the walnut color, so that you don't have a lot of color options with that company. The biocolors works on a piggybacking lens system. So as you can see here, so this is the tint, the iris pattern, and then there is a star burst. Okay, so that is just around the pupil area, and then there's a limbal ring, which is around the limbus, and then you combine all of these lenses, and that's what it looks like. So there is an underprint lens that you put first, and then you do the iris pattern, and then you do the starburst, and then the limbal ring. So these are 4 different contact lenses that you will stack up on the patient's eye, but the final lens will actually have all 4 of these lenses combined into one contact lens. Okay. So sometimes I also take a picture of the other eye and send it to the company. Okay, Orion is the one that gives us these lenses, or so sometimes we will have to talk to the consultant and then, discuss and then see, which of the iris patterns might most, closely mimic the other eye's iris pattern. And so the lenses are designed, and they come in varied base curves and powers and diameters as well. The most important thing is clear pupil and black pupil. Sometimes you might have a completely, opaque cornea, and then you will have to use a black pupil so it mimics the other eye. In this case, he still has a pupil. He still has some vision out of the not so good seeing eye. Okay, and so you want to do a clear pupil, and then to do the clear pupil, again, you will have to measure the other eye's pupil diameter, in light and in dark, and then you will have to kind of do somewhere in between. Okay, so you also inform the patient that it will look a little different, but then when you look from far, it's not that prominent or that obvious to be able to know that they're having some, weird looking contact lens. So this is how the lens looks. So this is the prosthetic contact lens in the patient's eye. As you can see, so I have completely covered this opaque area. He does have a dense arcus too that is not really seen with this contact lens. So we decided on the 8.6 base curve plano power, okay, because his vision is very little in that eye. He is wearing it clear pupil mainly for, making sure that he is aware of his periphery. And then 15.0 diameter, because there's varied diameter ranges that these lenses come in, and then 5 millimeter clear pupil. And this is the close-up, parallelopiped view of the lens. As you can see, this is where the pupil is. Okay, so he's still able to see out of the clear pupil, okay, to be aware. This is how he looks like. So when I last saw him in 2021, it was during COVID time. See, you cannot tell that he actually has a prosthetic lens in his right eye at all. So in his case, or in any patient who's monocular, they will wear glasses anyway. So as long as you get as close to the other eye as possible, that's all they want. Okay, so you want to have them look at themselves in the mirror just so they know how it looks like. And usually 95% of the patients on whom I have fitted these lenses, they have been happy. So this is the Penacam of the right eye again in 2021, showing the irregular corneal surface. So what's special about these? They can boost the patient's self-confidence, and then, they can help with vision or with visual field. You should always have a prosthetic contact lens fitting set, so the patient can see, what it looks like, so at least have one. There are other companies that actually make them, but you should at least have one. And there are some companies that can actually just, if you give them the base curve and the diameter, can just design the lens based on the picture of the other eye, and then you can just give them the prescription also. And protective eyewear is extremely crucial for only, if they have only one good seeing eye or good eye. That's all I had. Now I'm open to questions.
Thank you so much, ma'am, for that wonderful case sharing, and also, taking us through the lens design and the details of the lens itself, because that is something which is important, how the design is and what are the other options available, so that when we have such patients, we are aware of the opportunities we have for them. So that's really very important. Thank you so much for sharing that with us today.
No problem.
Okay, so I think a couple of questions you did cover up a little bit, but one of the question was regarding the ABCD classification. Have you tried using the ABCD classification nomograms to see if there was any changes due to the contact lens, or the cornea is warped instead of, the keratoconus getting progressed? Do you think because of the lens warpage and things like that, would that change? I guess that's what I understand.
Yeah. Excellent point. Yes. So when there is some amount of warpage, there is you will look for those changes as well in the topography. To be honest, most of our contact lens patients are now in scleral lenses. And so when I use the ABCD, I am less concerned about corneal warpage, just because the scleral lenses vault on the cornea. So, they don't do anything to the cornea at all. So I know that I have a more accurate progression display, because they are wearing scleral lenses. Now, having said that, I do have patients who are wearing the gas permeable lenses or hybrid lenses. So if there is true warpage, or if there is anything going on the cornea because of the fit, because you have actually looked at the contact lens itself in the eye, you will know, if this is a bad fitting lens that is actually causing some corneal trouble, and if that is what the topography is picking up, or if this is actually a good fitting lens that is less likely to cause any of the problems in the cornea. And so, the topography is more reliable and it is actually showing the true progression. Does that make sense? So if the fit is not as good, that the topography is probably going to be not as reliable, just because the lens is just a bad fitting lens. And so then you cannot, you have to be mindful of that, when you are actually discussing that with the patient. You say that the lens is not fitting well, so I'm not too sure about this topography. Or the lens is fitting great, so I know this topography is almost as reliable as it can be.
Right. Yeah. And I think probably the other thing would be, if you think that it's fit related, wash them out, or, have them off lens for a couple of days and repeat and see if you're getting the same results.
Correct. See, that is one of the main problems, with keratoconics, because they're so dependent on the contact lens. The washout is just so hard, because without their lens, they cannot drive, they cannot work. And so I have tried that and I have completely given up, because they will tell me that it is a washout, but then they will never do it. Correct. So it's very, very hard. If they are younger and if they are in school, it is easier to do that, rather than if it is an adult who's actually in the work environment, to have a washout period. And in that washout period, again, our corneal specialist will actually suggest 2 weeks. It's impossible for, these specialty contact lens wearers to be off contact lenses for 2 weeks and then do a topography to make sure that it is a true change. But it never happens in reality.
That's right. Yeah. So that's something which we have to then totally rely on our clinical judgment of the fitting. At least we have that in our control, right? So if the fitting was good,
exactly.
we know that it's not fit related. It's a real change in the ocular tissue. But
exactly.
If you have a doubt in the fitting, then probably that's the case. So that's something which you can always take it up. The other question which I think came up was, for the fourth patient, I think for the scleral lens patient, would you also recommend doing scleral topography, or do you routinely have an opportunity to do scleral topography as well in fitting scleral lenses?
So unfortunately, we do not have a scleral profilometer in our clinic. So I can only do corneal topography. Even though the scleral lens vaults on the cornea, at least I have, some information is what I go by. To answer that, yes, if you have a scleral topographer, please do it, because it gives you a lot more information. You have less visits with the patient, and you can design the lens quicker, easier if you do that.
That's right. Yeah. And I think nowadays, in your lens description also, you mentioned that the lens already was having some toricity in terms of the scleral zone, or probably the profile of the lens is always toric. So correct. We hope that that would help us in terms of fitting, but scleral profilometry is something which will be a great tool to make it as a starting point if possible.
Definitely. Yes, I wish we did. We are still working on getting one.
That's right. Yeah. Wonderful. Great. And I think one last question which came to me directly, so I've not put it up on the slide. It says about the multifocal patient. Is there something which you look in particularly to decide the design of the lens? Are you going to go for a translating design, or you prefer a concentric? Is there something particular you look? Is it the lid position which is the most important for you, or is it the patient's lifestyle? Anything in particular which you see in a patient which helps you to decide? Any tips on that?
All of it.
Okay.
All of it.
Yeah.
Yes. So patient's age, and then patient's occupation, patient's lid positioning, their expectation, and then previous lens history, all of it plays a part in determining what contact lens works for the patient. So the age of the patient is also there. And then, if I have an older, older patient who has already worn gas permeable lenses like this guy, but he was wearing monovision, but then they don't do a lot of computer work. The one downside is the older the patient gets, the more loose their eyelids are. So it is very hard for them to translate, so they don't, they're not like younger patients whose lids are tight. And so they can actually translate very well. The loose and flaccid lids don't translate as well. So you have to take that into consideration as well. I actually can remember, two of my patients, of all the multifocal contact lenses that I have fit, one actually has the trifocal, like an executive bifocal, but then it has two lines on it, and he has been extremely successful, even though he's a little older, but he has gotten used to that design, and so he has the translating design. And then I have another patient who actually has just one line. So it is like an executive bifocal, and then who also is very successful. But, it is very easy for those patients to also be, switched to an alternating, to the aspheric lens design. Sorry. Yeah.
Yeah. Wonderful. Great. So I think with that, thank you so much, ma'am. We have covered most of the questions, and I think you did a couple of sharing of the questions as well during the session. So we have taken up most of the question. Thank you so much for spending your Sunday morning and sharing that huge information with us. Thank you so much.
Okay, thank you so much for having me, and happy Diwali to everyone.
Yeah, happy Diwali to everyone. And we also have a couple of session plans over the next weekend. Until then, take care, be safe, and enjoy the rest of the days with the festivities. Take care and bye-bye.
Bye. Thank you.
Bye. Have a good day, ma'am. Bye.
Yes, thank you.